Welcome to tonight's webinar on essential risk management strategies for practice owners and healthcare directors. In the spirit of reconciliation, event acknowledges the traditional custodians of country throughout Australia and the connections to land, sea and community. We pay our respect to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. I'll now hand you over to our Events Risk Manager, Practice Specialist, Angela Mason, who's a moderator for tonight's conversation. Over to you, Ange.
Hi, everybody. Welcome. And my heart goes out to everybody in lockdown as well. Look, tonight we're going to work through some pretty difficult topics and especially difficult for doctors sometimes. I suppose as a risk manager with Avant, one of the things that I get to do is look at when risks have actually eventuated in a claim or a complaint. So we'll be working through what you can do to prevent things from going wrong in your practice. As Sterling said, we'll be answering a lot of the questions. We did receive quite a lot of questions and we've tied that into the presentation. So a lot of them will be answered. And of course, if you pop them in the chat box, we'll hopefully get to those as well. So we're going to work through a risk management framework and what that looks like in a practice, in a healthcare practice, and particularly looking at the governance culture throughout the practice. We're going to look at how you can do it holistically and involve the whole practice. We'll look at how the processes are behaving in your practice, their efficiency, if you like, and how to stay on top of those emerging risks. So certainly running a practice means you have to have a pretty good knowledge of business. And in my role as a risk advisor, I often see where great doctors open their own practices because they want a certain style of practice. They want a great practice. So they open their own practice and they're usually great doctors, but they're not always great business people. So tonight we've got a few experts on the panel. I've got somebody talking from a business governance perspective, so what the business is supposed to look like. Then we've got a doctor with experience who's going to talk to you about how that looks in a practice when you're running your own practice. And then, of course, we've got a practice manager to talk about the practicalities of that. So I'd like to introduce our panelists. We've got Catherine Maxwell, the General Manager for Policy and Advocacy with the Governance Institute of Australia. Catherine oversees the policy direction and advocacy initiatives at Governance Institute of Australia, a national membership association that advocates for a community of over 40,000 governance and risk management professionals. Catherine's got a strong background in governance and policy gained through the Australian Prudential Regulation Authority, the ASX Corporation, Governance Council through ASX, the Australian Institute of Company Directors and the Financial Services Council. She's qualified as a lawyer and she also has held roles as Company Secretary for the Cancer Council of New South Wales, NPP Australia Limited and Father Chris Riley Youth off the Streets Limited. So welcome, Catherine. We also have Riwka Hagen, who I've known for a long time. What a wonderful lady she is. Principal consultant with Medical Business Services. Riwka started her professional career as a medical scientist. She successfully implemented and managed a regional laboratory of a major pathology provider before embarking on a career of medical practice management and general practice accreditation. Riwka has managed small, medium and large medical centres and has a strong interest in quality improvement, governance, business planning and financial management. She's the Director of Medical Businesses Services, providing consulting, advisory and training services to the health sector Australian-wide. She's also an experienced board director in the health sector, recently retiring as chair from COBAR, I think I've pronounced that properly, Community Health, leading a $10 million building project and successful merger. So welcome, Riwka, great to have you. And then we have Dr. Colin Goodson. Colin trained as a GP in the UK. He was a partner in a large UK practice and a member of the local UK clinical commissioning group before immigrating to Adelaide in 2012. He became a co-owner of a group of 4 practices in the northern suburbs of Adelaide, then joined the Better Medical Group in 2019. and he's currently the CMO of Better Medical Group. So Colin believes strongly that good clinical governance is the key to successful general practice organisation. So welcome to you, Colin, as well. It's great to have the three of you here. I'm sure we're going to benefit from your vast experience and knowledge. I'd like to actually get Catherine to kick us off with a bit of she's just going to give a brief presentation on the risk management toolkit, if you like, or framework that's expected in practice. So Catherine, could I hand over to you, please, to start us off?
Absolutely. Thanks so much, Angela. Now, I don't have COVID, but I do have croup. People my age do not get croup. I don't know how that's happened, but anyway. And unfortunately, I might have a lot of medical specialists in front of me, but none of you can actually treat me. So let's get started. I think I'll just start my slides and we'll go there. All right. So what we're going to talk about is risk management for practice owners. I think certainly the last 12 or 18 months have showed us that medical practitioners are essential for their community. They have to have workplaces that are well run and well resourced. Trust is really important. We're seeing that playing out, I think, in the public in terms of the whole vaccination program. They play a really critical role in ensuring good governance, and that risk management is a really important part of good governance. So I'm kind of going to talk about three things tonight. I'm going to talk about risk management frameworks. Sounds a bit scary, but actually if you break it down, you can get your head around it. Setting your risk appetite for your practice, and then linking risk and culture, because it doesn't matter what documents you have. If you haven't got a risk-aware culture, risk in your organisation or your practice is not going to get off the ground, or a good risk management is just not going to get off the ground. What is risk management? How can it help your practice? Well, risk is the effect of uncertainty on the practice or an individual achieving their strategic objectives and maintaining your long-term viability and reputation. And the other thing to remember is risk is not just about threats, it's also about opportunities. It's a two-sided thing. So risk management really helps you develop strategies to identify and manage your risks and the threats that your practice faces, but also to manage and, where appropriate, leverage uncertainty for the benefit of your practice. And I've just listed up there on that slide some of the threats that you might face. Obviously, I think if you've been talking to risk management people in recent times, the whole of the last 18 months, I think, has been a stress test of people's risk management and crisis management plans. But also that, think about the opportunities. But certainly risk management, if you look at the jigsaw pieces on the right-hand side of that slide, it means if you have good risk management, you'll be ready for opportunities, you'll be prepared for the worst, you'll avoid losses, and your current business will be fit to continue. So risk management is very important. Okay, so this next slide I've put up for you is the sort of 9 principles of risk management according to the International Standard. And there are international standards on all sorts of things. But if you look around that circle, so it's integrated, it's structured and comprehensive, it's customised, it's inclusive, it's dynamic, it's based on the best available information, takes into account human and cultural factors, and it's continual improvement. And then there at the centre, which I guess is the reason why you're doing it, it's creating and protecting the value of your practice. So they're really the 9 principles. And I think 3 things that I really want to emphasise in relation to that slide are, it's dynamic. You have to keep on top of it. There's no point producing a whole bunch of stuff for an accreditation or in response to an incident and then filing it away until something else happens. You've got to actually keep working at it and looking at it. I think the other thing to remember is no one size fits all. So what's appropriate for an enormous group of practices is not going to be suitable for a very small practice, but the reverse applies. So it's got to be fit for purpose, fit for the organisation. And this kind of comes in under the human and cultural factors. Leadership's really important in relation to risk management, because GPs and heads of medical practices play a really critical role in managing risk well. Okay, so I've just done a bit of a word cloud here in relation to risk management frameworks. There's a whole lot of words that if you get deeper into risk management, you'll start to see these words used, and it can be a bit confronting and a bit scary. And certainly, look, I am not that familiar with doctors, but I'm certainly familiar with lawyers. In fact, I'm married to someone who runs their own business, and I would definitely endorse Angela's statement that, people who are very good at what they do are not necessarily very good at business. So what applies to doctors also applies to lawyers. But if you can get on top of risk management, it means you can not just be a really good practitioner, you can also run a practice that's going to keep going and be sustainable over the long term. This is a risk management framework. So a risk management framework is really it's the foundation of effective risk management in your organisation. So it outlines your approach to risk and identifies the types and levels of inherent risk that you need to manage. So it can assist you in identifying opportunities and strategies to improve the management of risks, provide an evaluation of how well your controls are functioning, the controls you have, increase the level of risk awareness across the organisation, and also give you a common language to manage, to talk about risk. And that's really important. You don't want to be talking about different things in different terms, because then you're not going to have this shared understanding. You can use it to factor risk into just management decision making. So you can actually look at risk when you're making decisions in relation to the practice. And it can also improve the operation and targeting, the coverage of your insurance program. So there's a lot that a risk management framework can do for you. I've put up here, this is the Queensland Government Risk Management Framework. So if you're interested in having a look at that, you can just find that on their website. But it's quite an easy one to have a look at, and it talks about what risk management informs. They call it an enterprise risk management framework. So that just means it relates to a large organisation, so the enterprise. It talks about why they manage risk, sets out the risk appetite, the process, and then talks about the elements of the enterprise risk management framework. So it's just quite a good visual representation of what a risk management framework looks like. But you can also do it as a document. I mean, that's another way of doing it. But I think the key elements of risk management frameworks are that there's a statement or a commitment to managing risk. And I think that's really important. The whole purpose and your outcomes of a risk management framework, what the elements are, what your process is, categories of risk, which is really important. And then other things that you might put in a risk management framework are sort of roles and responsibilities. So who's responsible, what role do people have and what they're responsible for. You might put links to relevant documentation, and you can see underneath the circle on the left-hand slide, or certainly my left hand, it's got the supporting resources. So that's the links to the relevant documentation. And the governance framework is something else you might want to put in there. So I just put up here the types of risk, and these will be, it's probably fairly obvious what these are, but strategic risk. So these are typically risks that come from outside the practice, but really are going to impact on your strategy, on what your plan is for getting to where you want to be. Operational risks, things going wrong inside the operating of the organisation. So the computer system, what is the risk of all the computer systems breaking down, that sort of thing. Cyber risk, certainly people are talking about this a lot at the moment, particularly because everything's online. People risk, very important for the medical profession, because you are relying on people to deliver services. So, people risk is a really important one. Governance is obviously another risk, the risk of not having an appropriate governance framework in place. Financial, if you don't have money, you can't do much. So what are the risks to the financial health of the organisation? Legal and compliance. And then obviously a very big one in this sector is clinical risk. So these are kind of the types of risk. So thinking about these types of risk, let's get on to the next tool, which I wanted to talk to you about, which is setting your risk appetite. So what is a risk appetite? Well, your risk appetite basically balances the need to take risks in order to grow or innovate with the need to avoid reckless behaviour that can hurt the practice and potentially your patients. So as a practice owner, you can set your risk appetite. So, for example, a small community medical centre may want to raise funds for some really much needed equipment, but they aren't willing to risk their brand or values or their reputation in the community to do that. Or another example would be a group of medical practices wants to improve the technology that supports the business. So they're quite willing to take the risk of minor disruptions to their services, so perhaps that things are offline for, half a day while they upgrade everything to the service, if they can actually get better efficiencies overall. So that's kind of trying to illustrate for you what a risk appetite is. The other really important thing is that your risk appetite needs to align to your strategic objectives. So your risk appetite will really drive how you do business. So for example, if you're a conservative practice with a low appetite for reputational risk, you might decide to not move into a new area of practice that could impact your reputation, even though it might actually be financially quite beneficial. But then at the same time, this practice might have a strategy for aggressive growth. So how can it do both of these things? So it's got to be appropriate. So a practice with a strategy for aggressive growth, if they have, will really struggle if they have a low appetite for any type of risk. And so that's why your strategy and your risk appetite need to be aligned. And things that will influence your risk appetite are things like the life cycle where you are. Are you a startup? Are you a more established practice? Regulatory requirements, the economy, the political environment. Certainly, the practice of medicine has become intensely political, if it wasn't already in the last 18 months. Culture, another really important, what is the culture in your practice? What is strategic objectives? And then your financial position. So, are you in a position to actually execute on the strategy you have, and how will that impact on your risk appetite? The other thing to remember about risk appetite is that the personal risk appetite of the people setting the risk appetite, or who are in charge of setting the risk appetite, will actually also influence the risk appetite. So if you've got very risk averse people setting the risk appetite for your practice, you're probably going to have a very low appetite for risk. And I thought that I would just put up and show you, this is just a risk appetite statement. So it sounds a bit magical and complicated, but it's not really. There's just an intended application of the statement. This is for a company. It's Villa World, which is a builder of project homes. There's a commitment from the board. There's a high-level overview of the risk appetite. And then the risk tolerance statements are aligned to the various risk appetite, to various risk categories, which are the categories of risk that we looked at a couple of slides earlier. So that's it doesn't have to look like that, but that's what a risk appetite statement can look like. So how do you go about doing a risk appetite statement? Well, you've got to establish your strategic objectives, figure out what your maximum risk capacity for each risk category is, so, low, medium, high. Determine the level of risk that the practice has the resources and the capability to really support confidently. So establish a risk appetite or comfort level. Comfort level is another good way of communicating the notion of risk appetite for each category. Have a statement that's really concise and clear so that everyone can understand it. Test your statement with people who are actually going to have to use it to make sure it's clear and usable. No point doing a statement if people don't get what you're talking about. And then have a look at your risk management framework to make sure it actually supports your risk appetite statement. So they're kind of 7 steps that you can do in terms of preparing your risk appetite statement. And then finally, culture. So having frameworks and a risk appetite in place is just not enough. Effective risk management really comes down to the people within the practice who operate within or outside the framework of the risk and the risk appetite. So it relies on the practice's culture. And I've put up on that slide various media headlines. A number of them relate to the medical profession, but we've also got a couple from the banking sector and also from the aged care sector. And there have been some very high-profile royal commissions in relation to banking and financial services and also aged care. And that just shows you some of the headlines which have really identified sort of cultural issues. So what's culture? Well, culture there's lots of, not lots, but there's a reasonable number of definitions. But I guess one that I find quite helpful is culture is what people do when no one's looking, or the way things are done around here, or the character and the personality of the practice, or the expected and accepted, because what's expected and what's accepted, and we're seeing this actually playing out at federal parliament at the moment. We've had a lot of scrutiny of the parliament as a workplace, of the behaviours in those practices. And then the values and the norms demonstrated by people within the practice. So if you translate that into a risk-aware culture is really the way we manage risks around here, or the risks people take when no one's watching, and the values and norms demonstrated by people within the practice in relation to risk. So, for example, you will have a statement up in your dressing, in the room where you do your dressings, about how you practice sharps. But when the practice manager's not looking, people just throw them in the waste paper basket. So that's a real indicator that there's a problem with the risk culture in that particular practice. So that's really how it works in terms of, it's really, you might have staff, if you don't have a good risk-aware culture, you'll find employees making decisions based on short-term gain without really considering the overall risks to the practice from what they're doing in terms of risk management practice. So how do you create a risk-aware culture? Well, what you do is, a good place to start, assess your current culture. There's quite a lot of ways to do that, but I'm sure Riwka will probably talk a bit about this, but you could do a survey to establish what your culture is. Identify what good looks like for your practice. And that's an important discussion to have. And you need your leaders to actually agree what good looks like for your practice. Then build risk management capability. You want to set your employees up for success. You want them to be good risk managers. And you might need to look at people's job descriptions to actually see whether there's any responsibility for risk management in their job descriptions. Then look at implementing a cultural change strategy. And then finally, monitor and review. So keep an eye on what that is. Now, that's a bit of a kind of rocket through some important concepts, but I just thought I'd finish by looking at some of the risks for medicine in 2021. So cybersecurity, and this is across a number of sectors. We're seeing this emerging in all sectors of the economy and business. Clinical quality, I think, will always be a risk. Patient safety, similarly. Emergency preparedness. Third-party suppliers, you are reliant on other people to provide stuff for you. So, what are your third-party supply chains like? Telemedicine. So many medical services are now being delivered by online. So, what are the risks associated with that, and how does that work? Government and politics. We talked about that in relation to one of the earlier slides. Legal and regulatory compliance, always an evergreen. And then I think that last one, workforce, really important because you are relying on people to deliver what you do. So I think that's kind of a bit of a gallop through some risk management concepts. And I think it might be time to I think my voice is just about at its limits. So perhaps it might be time to take some questions and unpack some of those concepts a bit further.
I think, Catherine, before your voice does completely seize up on us, I do want to just ask you one further question, if you don't mind. So you mentioned the word governance, and I know that is actually a new word to doctors in a lot of cases. Can you, in a sentence, or a couple of sentences, tell us, what does it actually mean? What's governance mean?
Okay, well, I was thinking about this earlier. You might hear a child say, "I am the boss of me." So how does that unpack? Governance is really about, do you reinvent the wheel every time you do something, or do you actually have a structure and a process in place so that you do things and you have a framework for how you do things? It's really about, power is kind of an odd word to use, but it's really about how authority flows through an organisation and how you make decisions, and it's also about making decisions ethically and responsibly, and it's about risk management, really importantly.
Great, thank you. That just was very succinct and lovely. Thank you. Colin, I'm going to go across to you now because we have had quite a few questions come in about, large organisations and as you start building. So you're the CMO of a pretty large organisation. I think you've got about 85 practices now. Those practices need governing. So how do you do it without visiting them every day? What's the trick?
I'd love to go and visit the practices every day if I could, but you're right, we realistically can't get out there every day. But I think that the key is having the framework in place. So you need to have all those policies and procedures in place and readily available for people that want to have a look at them or understand them. And you have to be able to communicate those policies to people and be aware of how things operationally are actually running in the clinic alongside those sort of policies and procedures. And I think in some ways, actually being a bigger organization, that's a lot easier because we've got full-time professionals in all areas of the business to stay across the legislation, to stay up to date with whatever's required in HR, finance. We've got an operations team, and clinically, my team, that we've got a clinical advisory board of doctors to set our policies and procedures. So policies and procedures for us is easy. The challenge for us as we get bigger is communicating that down to the clinics, and that's where it's maybe easier in your own smaller clinics. So when I ran my own clinics, it was easier for me. I could go and see everyone every day, and I knew exactly. I had a really good pulse and knew exactly what was going on within the organization. So the way that we manage that through our organization, we've mirrored our operational structures with our HR structures, with our clinical leadership structures. So we have on-site clinical lead and managers. We have state clinical leads, HR and general managers, and then we've got the national support office. And so there's really easy structure. Everyone knows who to go to. It's very easy to communicate for us with the practice, or with the practice if they have an issue. They know who's the right person to go to, who they can communicate with. And it means that we've built that trust. So we have that trust. And really what we're doing is trusting the clinics at a site level. They're all very different, different sizes. They operate differently, but they know what our expectations are. But that they're in a way free to have their own procedures to achieve those policies, and that works well for us.
Yeah, that sounds great. Thank you. I bet there's a lot of hard work that goes into actually doing that. So I appreciate that. Riwka, I'm going to chop across to you now, being a practice manager or a practice management consultant, and knowing how these things work practically. Tell me, what sort of things do you look for in a practice to work out if they've adopted good governance systems?
Thanks, Angela. Look, I guess my answer to that is that really both Catherine and Colin have touched on so many of those areas that are just so indicative of, whether risk is more likely to rear its ugly head and kind of bite you on the bum. But look, I think for me, the sorts of indicators that kind of give me a good sense of good governance is the adherence to and achievement of accreditation standards. So if there has been some sort of scrutiny over policies and procedures and systems, then that's kind of, a step in the right direction. It's not the be all and end all, but it is one of the indicators. I think also just the formality around that documentation, the processes, the systems and policies that underpin how you do what you do, as much as, especially for the smaller practices, these are the things that kind of make them go, it drives me crazy. But these are the roadmaps that kind of tell us, the rules of the game that we're playing by. So the structure around that for me is really important, whether the practice is large or small. I think they're very important. So policies and procedures are all good and well, but the next step is really the adherence to them, isn't it? So is everyone actually, on board with the words that are on the page? And often this is where that disconnect really takes place as well, that everyone's kind of got their own way of doing things and the systems become loose because there's no structure or discipline around how we do things around here. And certainly Catherine has reflected on that. Just a couple of other ideas around that. So effective position descriptions. So do people actually know what their role is around risk within the practice? And really these ideas ought to be reflected in pretty much everybody's position description to be risk aware and bring that to the fore. So that can be important. Just reviewing and the systems and processes within the practice or within an organization when things have actually gone wrong. So how are adverse events actually managed within an organization? What's the culture around recognizing that and that sort of self-reflective piece around, well, what went wrong and what are the systems issues that underlie that? And that's frequently the case. So really the structure around how that plays out in the practice, that's a huge indicator of that sort of governance maturity. And a couple more patient feedbacks. So what are your patients saying about you and your service? Similarly, what are your staff saying about the practice? So do you tap into them and ask them what they think are risky procedures within the practice? And, certainly Catherine's pointed to sort of the organisational culture. You really can't shy away from that. It just really underpins absolutely everything. And I guess just that openness to questioning how you do things within your practice, and whether it's part of that open disclosure process or whether it is just that maturity and comfort and trust that's built that allows an organization to say, you know what, in some areas we don't perform as well as what we could and what we would like, and just even being aware of that can be a really good hallmark of that sort of risk maturity. And finally, I think practically a risk register, and it needs to be a tool that's easy to use. So you've got to have your documentation that's easily managed, especially for the smaller practices. You do not want a risk register that's 40 pages long, because it's unwieldy, it can't be done. Love dot points, love Excel spreadsheets, keep it simple, but note it all down. And, I think put all of that together and you're kind of heading in the right direction.
Brilliant, Riwka. Love it. Thank you. Colin, Catherine talked about risk appetite. How do you establish a risk appetite, say, with Better Medical? How is that established?
I mean, I think, so Catherine covered that really nicely in the talk. And I think for us, the risk appetite it's set by the board. We're a big organization, we've got a board, and they set their risk appetite, and they align that with the strategic objectives for the whole organization. But I think generally in healthcare, there are certain, our risk appetites in certain areas, no matter what the scale of the organization, are going to be very similar, particularly around sort of clinical practice and regulation and governance. But where it may differ is around that financial risk and innovation risk. But what I was interesting when Catherine was talking, what I was thinking was actually when I ran my own clinic, where we didn't really consider this formally, but how it actually would have been really, really useful, because we as a group of owners actually had a different tolerance to risk. And that ultimately led to some difficulties because we didn't have that written down. And when something came up, we weren't able to refer back to a bit like that partnership agreement or something like that. So I think having discussed risk at that kind of leadership level is really important. But with Better Medical, the risk appetite is set by the board, and the risk appetite statement that the senior sort of executive team are party to. It's not as formal as that document that Catherine showed for the government organisations. So we'll have that. The clinics, though, will also have their own, because they're all very different. They're all independent. They're all in their own communities, and they want to serve those communities. So if a clinic came up with something they wanted to do, that would be discussed further up the organisation and held to the risk statement. Does it fit with our strategy? Does it fit with our risk tolerance? And if so, then we would work with that clinic to implement it. But that's how we manage our risk appetite at Better Medical.
Catherine, have you got questions that you would ask if you were trying to establish a risk appetite?
Well, I think what you do is you go back to that slide and you look at, in terms of the process. So, you start with your categories of risk. And I was listening to Riwka going, there is no point having a risk register with 147 risks on it. You just... And I have seen those. I've actually worked in organisations where I think we've had, risk of space lab hitting the building almost. Crazy. You just can't manage that. So you go through, I don't know how many people have done it, but, you go through the process of looking at, okay, well, what's our appetite? Likelihood, consequence. There's a whole process you can go through. But, what is our appetite in each category of risk? So just trying to think of an easy example. Yeah, so, we have I suppose it's that example I actually gave when I was going through the slides. We're very risk averse, so we're probably not going to get into cosmetic surgery, but we've got a very aggressive growth target. So that kind of doesn't fit together.
Right.
So it's got to be aligned to your strategy, but it's really looking at, what is our appetite in each category of risk? And I think Colin made a really good point around the sort of clinical, the risk appetite for a lot of medical practices in a number of areas will be very similar. You don't want poor patient outcomes.
Yeah.
But there are other things in terms of, as you said, innovation, where the practice Colin runs might be quite different to the practice Riwka runs.
Yep. Riwka, when you go into practices and you obviously talk to the practice owners, how can you establish if they've got the same risk appetite?
Yeah, I think Colin actually already described that really well, that the hallmarks of differentiation and unalignment or disalignment, I guess, is if there is some conflict around, the strategic objectives and where, where are we sailing this ship? So that can kind of really sort of point to that difference of thinking, and can be a hallmark of different risk appetites as well. And I guess, for me, I really encourage practices to really reflect on these sort of core themes on a regular basis, because it really sort of distills that thinking a little bit further. So what I see a lot of practices and practice owners do is they feel very comfortable in the operational space. And so directors' meetings, they just become operational meetings. They're very focused on process and what we do, rather than taking that step back and looking at the bigger picture of strategy and of culture and of your objectives, and certainly of risk, and therefore risk appetite as well. So I think, sort of really becoming more disciplined around stepping away from what feels comfortable to having the conversations that actually require practice owners to dig a little bit deeper and have more foundational discussions around what is it that we have here, and where is next for us. And if there is a disagreement there, some disagreements might be okay. They are just, there's different ways of achieving similar objectives. But some of the disagreements can actually be, quite indicative that there are foundational issues that could be very risky for the organisation as a whole. And certainly I see a lot of this where practices are really struggling because there is high-level discord at the director level. And that's very uncomfortable, of course, for the practice owners, but certainly for the practice managers and the practice staff. These things can't stay hidden forever. So these things really deserve a lot of attention and a lot of focus and a lot of nurturing.
Yep.
I'm pleased to see the doctors do that stuff too. I mean, it's a very common problem that you often get boards who, and particularly you often get boards who have been, quite successful executives. And so they immediately go to what they know, which is the operational side of things. And it's lifting the conversation up that level and being more strategic about, so, where is it that we are going? And you'll often look at your whole risk appetite in the context of your strategic planning. If you do an annual strategic planning session, you'll actually probably re-look at your risk appetite statement while you're doing that.
Yeah, very much.
That's great. Thanks, Colin. Colin, did you want to add anything to that? Because we're really sort of talking about culture here, aren't we?
Yeah, no, I mean, nothing significant to add. I think a lot of it's been said, but certainly that last comment there about the risk appetite going hand in hand with the strategic plan is absolutely true.
Yep. Colin, while I've got you talking, can you just talk me a little bit through what changes in the risk and the culture and everything when you start looking at buying more practices? So do you have some sort of a framework that you work around when you're looking at acquiring a new practice?
We do. We certainly do. And it's something that we've actually worked with our indemnity and insurance companies on, because that is particularly important. We have an acquisitions team, and as part of their due diligence, they will do quite a thorough risk analysis, as in-depth as they can. There's no expectation that any practice is perfect, but certainly if you see a clinic that clearly has a really good governance structure, that is extremely reassuring and extremely is going to make that due diligence process a lot more simple.
And when you actually take these practices on and say you want to get them to do something that they're not used to doing, that's, I suppose, a whole new challenge, is it?
It's a little bit of a sort of dating game. You hope that you are in many ways aligned, but yes, and we'll share with practices the way that we operate and the way that and be open and transparent about that. So hopefully a practice coming in is aware of any changes that are going to take place. But it's really trying to choose practices that have shared values from the outset. But none of the changes that we want to introduce, I think, is when it comes to governance, is there's not often a great deal of resistance to, because actually most clinicians want to work within an environment that is safe and well governed. But that's part of our selection process for the clinics that we work with, and certainly part of the due diligence process both ways.
And does that all, and sorry, I'm just answering some of the questions that are popping up here. So some of the questions we've had is about doctors that come into your practice as well. How do you govern them, if they're new to the practice? And I suppose it's the same sort of philosophy. Is that correct?
The majority of our doctors are actually independent contractors. So they will have a service agreement, and in there will be some wording around expectations, and we do have a code of conduct that doctors, all staff in fact, sign up to. But I think the real key to working with doctors and engaging doctors in governance is involving them in those decisions. So all our practices will have practice meetings, and what we've done to try and build that sort of culture of governance, and our clinic meetings have standing items. And in all those standing items, there are governance issues. So there's ethical issues, incidents, complaints, policies and procedure updates to keep people. So we're constantly using the language, even if there's nothing to discuss. It's constantly being raised, and it's just building that awareness that they're a partner in this. That our policies are aligned really with accreditation standards and with legislation, but the practice really sets the agenda for how they're going to achieve that and sets their own procedures to do that.
Beautiful. Riwka, I'm going to come across to you again now, and this is about compliance. How do you get compliance, and how do you check compliance?
Yeah, well, look, I guess it has to start with the practice understanding of which compliance frameworks are appropriate and applicable to their operations. So there needs to be, that skill base to have understanding of what underpins the compliance requirements. And, certainly the accreditation framework will go a long way to addressing some of the compliance requirements. But, I guess we need to think more broadly than just simply accreditation. Compliance is not accreditation. We work within legal frameworks, and, there are laws that we have to abide by. There are lots of laws we have to abide by as we're running through our day-to-day business. And many of them are not mentioned as part of accreditation. So I think it's just sort of a really broad awareness of all of the bits of legislation that underpin what we need to do. And I think, in terms of, how do we know that we're achieving it? I think that notion of, good systems, good processes, we've spoken about that a number of times now, and regular audit. So there needs to be a framework for stepping back and looking at it again and saying, is it all working the way that we expect? So you have to test it. And really large organizations have the benefit of using internal audits and even external audits to kind of shine the light on how are we doing things around here. And certainly, smaller healthcare businesses just don't have the capacity and the resourcing to be able to do that. But again, a more simple process around reflecting on what you do and how you do it, and testing those systems on a regular basis. That's really the way in which you hold everybody continuously accountable. A really sort of clean example of that might be annual vaccine fridge audit that needs to be undertaken. That's part of your accreditation compliance requirement. And that needs to be done on an annual basis, even though your accreditation assessment only happens every 3 years. So that's just one neat little example of going through a series of self questions to say, are the seals working? How are the thermometers going? Have we got our cold packs? What do we do when, you know, the temperature is gone on the vaccine fridge? All that sort of self-reflection. So that's kind of what you need to do around all of the compliance requirements. And of course, you want to pick the areas where you can't do that for every single thing in your practice. So you need to be picking the areas that represent the highest risk. So whether it can result in patient harm or significant business impact, those are your key areas that you want to be auditing and keeping a really, really close eye on. Don't jump down the rabbit warren and try to audit everything, or else you end up auditing nothing. So yeah, that's probably my best advice.
And also, you know, do it a bit, do some surprise stuff, you know, add in a sort of mystery area. If you're doing a sort of annual review, add something that you might not think about, you know, how are we doing on this? Interestingly, we did a survey of our members last year on risk management, and it was amazing how many organisations had not tested their business continuity plans and were sort of caught. I mean, I think people have caught up now, but certainly COVID-19 caught lots of organisations on the hop. And I think the other thing that I was thinking about when I was doing the preparation for this was, I don't think any of us thought we'd be in a second COVID year.
Oh, I did.
The crystal ball is better than mine.
Riwka, but look, I think, you know, really pandemic planning really comes into the space as well. So as part of accreditation too, pandemic planning has always been a requirement. And there are certainly, you know, fantastic guidelines available to help shine a light on the framework of the thinking behind what you need to have in place before you know what the actual agent is, that is your pandemic at any given point, but just familiarity around what are the systems and processes that you should already have in place before we even find ourselves in a crisis. So that's yet another example.
Yeah, oddly enough, the insurance industry was reasonably well prepared because they'd had SARS.
Yeah.
That
so
was
we might keep moving through because we're running out of time. Riwka, I have had a question. I just want to mention something. You've talked about accreditation and standards, and obviously general practitioners understand those words quite clearly, but if we've got any specialists online, they might not. So I just want to draw their attention to the fact that they have a set of standards as well, which is the Nsqhs Standards. So did you want to talk just very, very briefly on that? And then I've got a question for you that's come up in the chat box.
Yeah, absolutely. So I think, you know, certainly the National Standards for Quality in Healthcare, the standards that you're referring to, they're a fantastic reference, not just for specialists, also for GP practices as well. And there is certainly overlap between the RACGP standards and these other standards as well. And I was actually just recently reading about newly released standards around medication dispensing, which all healthcare organisations need to adhere to as well. So I think it's familiarity around both sets of standards really for everyone that can be really relevant. But for specialists, there is no reason why they can't download a copy of the RACGP standards either and simply reflect on the standards that are relevant to the service that they provide. And if they start working towards self-compliance there, then that's going to give them assurance that they've got all of those key risk areas taken care of, because that's really what the accreditation framework is all about, isn't it? It's you know, keeping our patients safe and having high quality services at the heart of what we do.
And some of their colleges obviously have picked up on the Nsqhs standards and written their own as well. And I'm talking, particularly about the ophthalmology. Look, Colin or Riwka, I'm not sure who would like to answer this. Somebody has said they're at a practice where clinically significant results are actioned with 2 phone calls, and then if they're unable to contact the patient, they don't do anything unless they're instructed by their GP to do something more. What are the flaws here? Colin, do you want to pick this one up?
Yeah, I mean, there are standards in those accreditation standards around the degree of responsibility that you have around those results. I think obviously it depends on the result itself. I think that's going to be important, and the individual GP ultimately, or the individual doctor that requested that test ultimately will be responsible for determining how much further you should be persisting in actioning those results. But yeah, no, difficult area.
And it's interesting because we only have a very scant look at what the process is, which Riwka, did you want to talk a little bit more about what a process like this might look like and how this is a perfect opportunity for them to review it?
Yeah, absolutely. Look, I certainly wouldn't be comfortable with a practice that just sort of routinely stops at 2 attempts and then kind of goes, oh, well, that's a bit tough. But for me, I'd be also asking around, how practices are collecting up-to-date demographic information on their patients. So what is their normal process for ensuring that we are able to contact patients? We know that we should be checking our 3 approved identifiers and that we need to be keeping demographic information up to date. How are your staff doing this within a practice? So this is one of those fantastic examples of where reception or admin staff perhaps not being as diligent can result in really catastrophic failure down the end. If you can't get hold of a patient, that's really devastating. So I think it needs a very full sort of root cause analysis to see exactly where the systems are being let down. That leads a practice to basically, have that kind of approach to managing clinically significant results. I do agree with Colin that the nature of those results also has a big impact on how far do you go, how far down the nth degree do you go, and of course, the more clinically significant results are, the further you need to go, and the more effort you would put in. But at the least, if telephone contact can't be established, then a registered letter where it has been delivered would be the minimum next step.
I think from a lawyer's perspective, they say that you've got to show evidence that you've actually contacted the person and that they've actually understood the significance. So they're the 2 things you've got to do, and how you do that is up to you, and that's only obviously for clinically significant. Colin, I've got a burning question that I love asking doctors. Accreditation. What does a doctor think about accreditation?
I love accreditation. I support accreditation. But if I go back a few years, that's very, very different. My relationship with accreditation, particularly when I first arrived, and I was just working with it within a clinic, was I was almost unaware of it going on. Except every 3 years there'd be this crazy panic where suddenly everyone was asking me for my information and my evidence of my CPD and my insurance certificate, and all suddenly policies were appearing and health and safety posters were going up on the wall, and you were you had this awareness something was going on, but it would occur, accreditation would happen, and then there would be going on for another 3 years, things would settle down again until that was frustration. I didn't engage with it. I didn't engage with the policy. Now, being involved in accreditation, becoming a practice owner, I think we're very fortunate in general practice to have that accreditation coming around, although that 3 years comes around quicker than you think. But it's raising the standards, it's raising the practice within a clinic, and particularly if you develop your policies and procedures and then you adhere to them and you communicate change, it should be something that's very easy to achieve. I get frustrated by where accreditation is seen as something to be achieved. It's actually a set of minimum standards that clinics should be operating to at all times, and it should be something that's very easy to achieve. And actually, you should be working to set your bar somewhat higher than those accreditation standards.
And it is about governance, isn't it? Look, thank you for that. We have got to the end of our time, and I don't want to go over. We have got a question in the chat box about a staff member who won't get a COVID vaccine. We will answer that offline because it will depend on what state you're in. So we can answer that off time. We've had some other questions that we'll also answer offline. Can I just go around and say, I want just one very last key message from Catherine. Can you start your last key message?
Everyone should be a risk manager.
I love it. Colin, what's your key message?
Gosh, engage in the governance activities and have it as a standing item on your agenda, on your meeting agendas.
Yeah, good one.
Riwka?
Look, I would say don't forget that opportunity is the flip side of risk. So it's not all doom and gloom. Just keep those two things in mind together at all times.
Thank you very much. And thank you to the delegates for joining us. Look, Catherine, Colin and Riwka, I could sit here and listen to you for another hour. So thank you so much.
Special thanks to Catherine, to Colin and to Riwka for tonight. Some fantastic information there. Everyone have a great evening and thanks for joining us tonight. Take care.
Thanks all.